Should I go ahead and
We have already 12 people sign in, so you probably can
go ahead and start?
start.
Yeah,
Yes.
because it's gonna take a while and I have a lot of slides, so I probably better go ahead and start then.
Okay, perfect.
Awesome. So good morning, everyone. I'm Dr. Karakas, one of the pediatric neurologists and epileptologists at Northern Children's, and I'm gonna talk about neurostimulation in pediatric drug-resistant epilepsy today. So here is the CME code, and this is gonna be in several slides throughout the presentation. Don't worry even if you miss right now. And like I said, please don't mind my voice if I start to cough or something. So 1 second. All right, I don't have any disclosure. The objectives of my talk includes one, to learn about the different type of neurostimulation therapies in pediatric drug-resistant epilepsy, to understand the process of selecting suitable pediatric candidates for neurostimulation therapies in pediatric DRE, and to evaluate and compare the efficacy of VNS, DBS, and RNS in the context of pediatric DRE. So as you all probably know, epilepsy is one of the most common neurological diseases. Maybe it was the fourth one. So this is a data from CDC in 2015 showing that there was about 3.4 million people in United States with epilepsy, and with an incidence of 300,000 in adults and about 200,000 in pediatric. So from the same data, and they showed that just in Kentucky, there were about like 50,000 patients with epilepsy. And that means that there is a lot of job for neurologists and epileptologists for sure. So as the first standard care, we always try to treat these patients with epilepsy with anti-seizure medications. And as you see, over the years, there has been so many medications that has been developed, especially in last 20 years or something. There has been over 20 medications, and overall now we have about 30, 35 different seizure medications. And as you imagine, there's a reason why we have so many medications, right? Because like none of them works for all. There's no one good medication that works for all seizure types. There are so many different epilepsy types. People have different type of reaction to different medications and everything else. So doesn't matter, how many more medication comes out, there's always going to be some more people who are not going to be well controlled with seizure medications. And this is a really great data from Brody et al. In 2012, published in Neurology, showing the chance of seizure freedom with successive anti-seizure medications. You see, about 50% of patients were well controlled with just use of one medication. Then another 13% needed the second medication, and another 3% needed the third medication. So that adds up to about 65 to 66%, meaning that about 65% of patients are going to be well controlled with only a total of 3 medication. Afterward, doesn't matter how many more medication you try, chance of seizure control is going to be really less than 1%. So, if you imagine the combination, like there are 30 different medications, then you can have 30 times 29 times 28 different combination of 3 medication, but there's no need to, keep trying different combination to say, well, I'm done with the medications trial. So once you fail 3 medication, that's about it. You need to start thinking about something else. And this figure shows the effect of refractory epilepsy on patients' quality of life. You see, when you have epilepsy, you have persistent seizures. You do have adverse effect of seizure medication, because like you're on 3, 4 different medication, people, then feels like zombie and everything else. They would have tons of cognitive problems, either directly related to epilepsy itself or from the effect of, seizure medication. Then you have tons of, educational, vocational, social consequences. You cannot go to school, you cannot work, you cannot drive, you have to, you are kind of stuck at home. So you feel anxious to go outside because you feel like you may have a seizure at any time. You get depressed and everything else. You do have personality changes. So you do have a lot of restriction, and you have substantially decreased quality of life. You do have also increased risk of sudden unexpected death in epilepsy patients. So it's almost all like a vicious cycle. One follows the other. So you need to break the cycle somewhere. And once you break the cycle somewhere, then everything else gets better. So, okay, we have some treatment strategies. We've used seizure medication. Everybody, like maybe 65% is okay. But what about for 35% of those people who didn't get good control with the seizure medication? You can maybe do some lifestyle modification, maybe avoiding some triggers. Some people may try ketogenic diet, especially those kids who are intellectually disabled and everything else, or with YouTube, etc. But not everybody is going to be able to try ketogenic diet, especially in adult. It's going to be really hard. Some people are going to be referred to surgery for surgery. They are going to do, some sort of resective surgeries and everything else. And we do have neurostimulation, which is what we are going to talk about today. So neuromodulation implies the alteration of nerve activity by delivering a targeted stimulus, either electrical or chemical, to a specific neurological site in the body with the goal of reducing seizure frequency and severity. So it's always good to know about how we came to that point with whatever we are doing. So the history of neuromodulation goes all the way back to the 15 AD. At a time that they first did some sort of torpedo fish shock for pain, and I guess there was a kind of dark ages for another 1800 years or something. I guess nobody bothered to do anything. And then in 1874 they did some muscle contraction by stimulating human motor cortex. In 1886 they showed some stimulation of cortex in epilepsy patient. In 1902 they did a skin stimulation, they came up with some devices for pain. In 1938, they showed some EEG changes on stimulating vagus nerve in cats. In 1952, they showed intermittent vagal nerve stimulation decrease or eliminated chemically induced focal epileptiform discharges. And then similarly, repetitive stimulation of vagus nerve led to synchronized or desynchronized cortical electrical activity in 60s. They did some analgesia on stimulation of infraorbital nerve in 60s, 67. They came up with some spinal cord stimulator in 1968, 67. Then in 85, they hypothesized that VNS antagonizes hypersynchronous state using animal studies, and they first implanted a human with a VNS device. And then came the approval of VNS devices by FDA. And then we had, eventually RNS and DBS devices. So as we said before, in 2015, there were like 3.4 million of epilepsy patients, and 35% of them being refractory. That ends up being like 1 million of people or something, right? So it turns out that out of 1 million people with refractory epilepsy, only about 200,000 are being evaluated at level 4 centers. That's like, only 20%. Then out of this 200,000 people, only 3,000 get surgeries done. So there's a significant gap for the referral, almost 80%. And then even if you are referred, then only 1 or 2% were deemed to be surgery candidate. Then as you see, from like 1 million to just 3,000, what do we do for all the other patients? And then at this point, we say, okay, can neuromodulation be an option for many of these patients? So yes, hopefully it will be. And there are several different neuromodulation options in epilepsy, including open loop stimulation and closed loop stimulation. When we say open loop, it suggests that there's a kind of feedback system. You do some recording, and as soon as you see any sort of seizure activity, then you responsively stimulate back, and that's like that would be considered as open loop. Closed loop. In open loop system, there's just continuous stimulation going on. There's no like feedback system or anything. And there are like invasive and non-invasively done devices. So as far as invasive brain stimulation goes, which is what we are going to talk about mainly, VNS, DBS, and RNS, as those are the main ones that have been in clinical practice in adults and pediatrics so far. So you see there are several different devices. Those are the invasive one, meaning that, they need some sort of surgical intervention to implant those devices. So you see all of them have some battery. This is where the stimulation kind of happens, or the electrical activity is kind of generated. Those are the battery. In VNS and DBS cases, the battery can be implanted in the chest. In RNS, the implantation is done on the skull. And the reason is because the RNS device provides also some ECOG recording, like EEG recording. And when they tried to place it in the chest, they saw that there were tons of artifacts and everything else. So they could not place the RNS devices in the chest. So it had to be on the skull. So every one of them has this wire component, and here the wire component is. So in VNS case, the device connects directly to the vagal nerve. In DBS, the electrodes goes into the thalamus, And then in RNS, the electrode goes into wherever the seizures are coming from. And there are some other non-invasive brain stimulation that is done basically without any sort of surgical intervention. You just like bring the device close to the patient and do some magnetic stimulation or direct kind of current stimulation using some tools on the patient's head. So before I dive into some details of RNS, DBS, and VNS, I just want to make sure that everybody knows that there aren't really that many randomized controlled trials or anything in pediatric population, unfortunately. Most of the data is based on the adult data, but there's some slowly growing body of literature recently in pediatric neurostimulation. So I will show you some adult data and some limited observational studies in pediatrics. So to just have some comparison to give you some idea about the differences among those three. So the target for RNS is, as we said before, is ictal onset zone. Like you have to place the electrode in where the seizure coming from. In VNS, the target is just the vagus nerve. In DBS, it's basically a part of thalamus. It could be either anterior nuclei or centromedian nuclei. So the stimulation type, the RNS is a closed loop system, meaning that, again, it would read the brain waves whenever it kind of captures a seizure, then responsively it stimulates. VNS for seizure, it's considered as an open loop because there is no seizure detection or anything. It just continuously stimulates, but it can respond to increase in heart rate, and in that sense, it can be considered as closed loop, but for seizure, it's open loop. And DBS also similar to VNS, it's an open loop system, meaning that there's really no detection or anything. It just like continuously stimulates, and you can set the on time, off time, and everything else. So the great thing about RNS is that it provides daily ECOG electrocardiographic data. It can show you the electrographic activity from seizure onset zone. In the VNS case, it can show you the numbers of therapy activations. It can show you the numbers of changes in the heart rate and maybe extra stimulation and everything else. And DBS can provide you some information about local field potentials. So the most commonly used neuro device is VNS, and it was first approved in 1997 for focal drug-resistant epilepsy. It was FDA approved at that time. Currently, it's approved for kids older than 4 years of age, and it's the most studied neurostimulation device. There has been over 100,000 devices that have been implanted so far. So in our institution, I think since 2011 or something, there has been about 250 surgeries for VNS, and I think the youngest one we've implanted is about 3 months of age. So in VNS case, the generator, as we said before, implanted in the left upper chest, superficial to the pectoral muscle. The lead wire is tunneled subcutaneously and coiled around the vagus nerve within the carotid sheath. So the left side is chosen to avoid stimulation to sinoatrial node in heart, which receives the input from the right side, right vagus nerve. And you see there's some whirling of the cable over here in a couple spots. Neurosurgeon would do that so that there's some room for patient to grow and everything, or as they move around or as they stretch and everything else, so that the wire doesn't get like stretched and broken or something. So it's believed that the action of mechanism is through the modulation by increasing the activity in the nucleus solitarius and downstream projections to limbic system and thalamus, then locus coeruleus and the raphe nuclei. So several pathways has been suggested. As we said, one is that stimulation of brainstem, and then eventual stimulation of relay centers to thalamus and the whole cortex. By then, increasing the norepinephrine, increasing the GABA, serotonin, and decreasing the aspartate. So they suggest that it increases also cerebral blood flow to the thalamus and cortex, and then it does change some EEG activity, a combination of which provides some anticonvulsive effect. So there has been several different models since it came out. So initial one was just providing continuous stimulation without any additional settings or anything. Then came Aspire, in which they had settings for heart rate changes and everything. And in the Sentiva model, basically you can have auto-guided mode where you can change the settings every 2 weeks or so the patient doesn't have to come to clinic every few weeks to change the settings or so. So you can have nighttime or daytime modes. and then you can change the duty cycle and everything else. So it works in 3 different ways. In normal mode, there's a scheduled delivery, 24 hours and 7, and then it prevents seizure with long-term effectiveness. You can set this every, like 5 minutes or something, kind of like doing 30 seconds on, 5 minutes off or something, or you can, change the cycle as much as you want. With auto stim mode is basically just, it's activated by rapid change in heart rate, and you can change the threshold. So with the magnet mode, you can provide some additional activation by swiping the magnet. So with the hope that it will kind of decrease the seizure duration, or it will stop the stats or something as soon as the seizure starts. So the good thing is that it has the ability to detect and respond to heart rate increases that may be associated with the seizure. Some in-house data shows that at a 20% threshold, AutoStim detected 80% of seizure and stimulated 5-second post seizure onset. Here you see if let's say a patient's heart rate is about like 100 per minute at a baseline, and if it goes beyond 120, which is like 20% threshold, then it would immediately start like giving extra stimulation, and the stimulation starts as soon as like 5 to 10 seconds or something. So if you increase the stimulation threshold, then up to like 60-70% or something, then the duration that it is gonna start delivering the stimulation is gonna be longer. That's kind of like a trade-off thing. You can keep the threshold low, it will immediately, respond to any sort of heart rate changes, but then you will run out of the battery sooner, because then patient is going to have some sort of movement. With any movement, heart rate is going to increase. Even though patient is not having seizure, the device is just going to deliver extra stimulation, and you're going to run out of the battery earlier. But if you increase the threshold, then you're not going to easily pick up the heart rate changes, and it's just going to be late a little bit. So this data is from Epilepsy and Behavior in 2011 and by Elliott and friends, showing seizure reduction continues to improve over time. After 6 months, it was about 36%. At 1 year, it was about 52%. And after 8 to 10 years, it went all the way up to 76%. So this is an important data to show, especially in the clinical practice, because a lot of time, patients' expectation is that, they are going to get the device and next day they are going to already have some seizure reduction or something. But unfortunately, that's not the case. You need to tell them, hey, look, like even after a year or something, the best expectation is about 52%. And even after 6 months, it was about 36% or something. So they are not going to have seizure reduction immediately the next day. It's going to take a while. So this data is from Elliott in 2011, showing that early use of VNS therapy offers proven long-term outcomes for children at a critical time in their development. And the great thing about this data is that, earlier they got the VNS, better outcomes they had. And if patient had less than 10 years of seizure, then they responded better to VNS. That also suggests that, if you have any refractory patient, once they fail 2 seizure medication or something, please send them to a epileptologist as soon as possible. Don't wait, to try 100, a different combination and before you are done with the medication or something. Earlier you send them for the surgery or for those type of devices, then better their outcomes are gonna be. So we keep talking about focal epilepsies, but actually VNS has been used in generalized epilepsy, although FDA approved it for only focal seizures. In neurology in 1999, they showed that out of 24 patients, 11 patients with idiopathic generalized epilepsy has more than 50% seizure reduction. And some other data also showed significant reduction in, symptomatic generalized and idiopathic generalized patients, up to like 46 to 57% of those patients had more than 50% seizure reduction. So when it comes to the level of evidence, I think, the meta-analysis have one of the strongest, evidence level, and because it combines all sort of like clinical trials and retrospective or prospective studies, and it kind of shows you the big picture. And this was a really great meta-analysis published in 2021 by Dr. Ravindra Arya. He's from Cincinnati. It was published in a really great journal in neurology. So they combined total of 100 studies, and they showed the responder rates was about 56% at a mean follow-up of like 2.5 years or so. So you see over the years, there has been many more papers coming out, over like 100 papers, but overall the responder rates in almost every one of those remain somewhere between 50 to 60%. So VNS is great for epilepsy, but not only for epilepsy, it does help with some other conditions as well. This data show that VNS provides some reduction in depression scores, and two subsequent studies showed trend to depression reduction was independent of seizure reduction. When you have a control in your seizure, you then directly may have some improvement in your depression or anxiety and everything else. But this data shows that independent of your seizure reduction, you are going to have like some good outcomes in depression and everything else. So in 2005, FDA approved the VNS for adjunct treatment in the depression, interestingly, but the coverage was denied by Medicare, Medicaid, and I don't know why. So, and it does also provide significant improvement in quality of life. And, this data show that VNS patient with autism also had improved alertness, verbal communication, memory, school performance, and everything else. So quality of life improves independent of seizure control again. And this data shows that, there were several components that had really good outcomes, including memory, achievements, verbal skills, mood changes. Seizure cluster was around 56%, post-ictal period and alertness and everything else. And the benefit gets better over time, and the maximum improvement were achieved during follow-up period after 24 months or so. So, one of the most complication that we feared is not one of the most common, but one of the adverse effect that we feared most is SUDEP, basically sudden unexpected death in epilepsy patient. And they, had this study done following about 40,000 patients over 10 years and everything else. And they showed there was a significant reduction in SUDEP rates. So with VNS use basically. So not only helps with your health and everything else, but it does provide significant total healthcare cost saving. And this data show that after like using the VNS for about 1 to 2 years or something, people were able to save up to $20,000 after even 2 years or something. That means almost like $10,000 per year. So that's a great thing for especially I think insurance companies. They should definitely encourage VNS to be done more, because they are going to say at least $10,000 per year per patient. So the stimulation parameters are based on, output current, signal frequency, pulse width, on and off time. So there isn't really a kind of guideline or anything in terms of how you should, change all those settings and everything else. So you can just based on clinical judgment and everything else. So and there are a variety of combination to achieve optimal stimulation settings with a separate day and nighttime programming, especially in Sentiva model. You first start with increasing the output current. Once you maximize the output current, then you can start changing signal frequency or pulse width. Then you can decrease the off time and increase the on time and everything else. You can provide safely like total of 7 titration step without patient coming back to office and everything else. So, but be careful, stimulation at high frequency with on time more than off time can result in nerve damage. So yeah, it does great things. It provides a lot of good benefits and everything else, but like any other devices, it is gonna have some sort of adverse effect. And those are mostly associated with VNS therapy. Occur only during stimulation and generally diminish over time. They may be diminished or eliminated by the adjustment of parameter settings, and they may be controlled by use of magnet. So you see there are several different adverse effects, including hoarseness, cough, paresthesia, shortness of breath. If someone, I will show you another slide where I will show you obstructive sleep apnea and things like this can be also possible. Now, the most common is the hoarseness. It's almost like 1/3 of patients feeling something like this. But the good thing is that it improves over time. After like just 2 to 3 years or something, it went from like 29% to 2%. So if somehow patient cannot tolerate, yes, you can maybe tweak the settings and make some changes. Hopefully a patient will start tolerate more. But if you change the settings, but still, it doesn't decrease, but patient is somehow able to tolerate and everything else, don't just like turn off the VNS or something. Just tell them, hey, look, if you can somehow tolerate over time, you're going to get less and less, side effects. And hopefully at some point, it will be it basically. So some of those patients who got the VNS may have new onset obstructive sleep apnea, which is why it may be important to offer a kind of sleep study before patient gets VNS, just in case if they develop obstructive sleep apnea, then you would know whether it was a baseline thing or whether patient just start having this because of the VNS and everything else. So it seems like it can cause laryngeal irritation also in the smokers. Lead break can happen, especially in those with intellectual disabilities. One of my patient basically kept scratching the VNS, and then it just like kind of completely disconnected the wire and everything else. Like a neurosurgeon had to take it out and everything else. So the lead break will just reflect on the impedances. Impedance should be somewhere between 100 to maybe 5,000 or something. If it's less than that or about that, then you know that there's something wrong with the stimulation. So you need to send the patient to the neurosurgeon. So you should have, you should be careful in people with personal family history of cardiac conduction defects. If they had postoperative bradycardia, if they had bradycardia or systolic test in OR during the lead placement. So, or if they have any sort of lead break, then you should not do any sort of MRI because the lead is exposed and it can heat up during the MRI and it can cause the damage in the neuroendothelium. So you should be really careful. So talking about RNS now, it's the first, I guess, closed loop device that's used in the epilepsy. It relies on seizure detection and then responsively it delivers the stimulation. It's placed in the putative seizure onset zone. It got approved by FDA in 2013 for focal drug-resistant epilepsy for patients older than 18 years of age with 2 or less epileptogenic foci. So as most of the time, like we use things off-label, and we've been using RNS also off-label. And the youngest age we've done was about like maybe 5-6 years of age or something. We've done a few cases of RNS here at Norton Children's also, but I will show you some data from the other centers. In terms of mechanism, when people used to get surgeries and everything else done, they used to do brain mapping where they would deliver some stimulation to either stimulate seizures or kind of understand the eloquent cortex and everything else. And as they were doing this, they would sometimes stimulate some seizure, or they would see after discharges. And when that happens, of course, you want to stop it, right? So what they were doing, they would just like deliver some extra stimulation, and then those extra stimulation would abort those after discharges. So this observation then led to the idea of RNS, saying that, well, I mean, somehow when the seizure happens or when the after discharges happens, if we can deliver extra stimulation, if we can stop it, why not we come with a device that does this, that kind of reads, electrical activity of the brain and then detects the seizure and then just like stimulate responsively. So they believe that it works by altering the plasticity of relevant neural networks, and it suppresses cortical synchronization even in the regions distal from the area of stimulation. So that means that it doesn't only, inhibit the seizure just the moment that it happens, also eventually by altering the plasticity, it kind of changes the neural networks and provides long-term seizure efficacy, basically. So it has several uses. You can use it for seizure lateralization. There has been several cases where people, have done phase 1 workup and everything else, and they were not quite sure whether the patient was having just unilateral or bilateral seizures, especially in temporal lobe cases. In those cases, they placed the RNS in both sides, and after almost average of like 42 days or something, they realized that those who were thought to have unilateral seizure were actually having even bilateral seizures or the other way around. So that kind of, gave a great idea about lateralization and everything else. So you can use the RNS for detection, counting, reporting. You can have almost like a daily ECOG and everything else. You can have some idea about the long-term kind of circadian or ultradian patterns. If you know kind of somehow when patient is going to have seizure, or if you are somehow able to predict the seizure occurrence, then you can take some precautions. Say that patient hasn't had seizure for a while, but then you are expecting patient to have seizure. Then you'll know, okay, maybe it's time to just be extra careful, not to drive. Maybe make sure your medication is with you. Maybe take extra medication around those times and everything else. So it can give you an idea about all those things. You can have some assessment in drug response. You say you take certain medications and then you want to see how it changes the brain activity or EEG activity and everything else. You can have pretty good correlation. And in those where you are not quite sure where the seizures, whether from like right side or the left side, you know, you can place the RNS in those two places and do the long-term monitoring, and then have some idea about the number of seizures coming from each side. And depending on, you know, their neuropsych evaluation and everything else, maybe you can remove one focus instead of just keeping the RNS there all the time. So as I said, it's the first closed loop system. It monitors the brain activity, it detects abnormal activity, and then stimulates responsively. So it can give you an idea, a data about frequency, timing, and location of electrographic activity over months, years in a naturalistic setting. So the battery is embedded in the skull. This is just below the skull, but above the skull. It's not within the brain, it's just on the skull. So it can have up to 4 leads, but only 2 of them will be actively stimulating and delivering some stimulation and everything else. The electrodes can be either a cortical strip electrode or a depth electrode. Depth electrode goes all the way in the part of the brain, wherever the seizure is coming from, or it can just sit on the surface brain, basically. The good thing is that patient can, you know, use a wand and then, you know, download the information to a computer. From there, it can send to PDMS, which is patient data management system. And from there, the physician can look at, you know, the EEG data and can tailor the management accordingly. So this is, I just want to show you this picture in terms of how it looks, you know, like a device can sit anywhere, you know, it could be the parietal region, maybe a little bit more posterior, anything else, depending on how neurosurgeon feels. So the leads can go all the way down, you know, it can go into a really deep part of the brain. And then you can get a kind of CAT scan done and then see this. And by superimposing CAT scan and MRI, you can have a really good idea about where the electrodes are sitting, you know, so you will know where you are stimulating and everything else. So it can be personalized for each individual seizure fingerprint, you know, with the detections, physician identifies and programs neurostimulator to detect patient-specific electrographic patterns. And with stimulation, physician program device to automatically stimulate in response to specific patterns with the goal of preventing a clinical seizure. So you can, as I said, personalize the settings. You can make it more specific or more sensitive. If you make it more sensitive, then, you know, it will kind of detect all sorts of different electrical activity that is not even seizure or something, and then it will deliver a lot of stimulation unnecessarily. But if you make it very specific, then it can maybe only detect the seizures, but it will miss a lot of other stuff that may be seizures. So it's kind of, again, a trade-off between having a good sensitivity versus specificity. But for that reason, when the RNS is first placed for at least, you know, a couple months or so, we just keep the detection settings on without, like, you know, starting the stimulation. Once we have a really good idea about the patterns of the seizures and everything else, then we start like stimulation settings. So this is kind of how it looks, you know, when you get the ECOG data. It can record, and this data can contain ictal, interictal, or baseline activity. Long episode is where you have some electrical activity going beyond a certain duration. It could be, you know, you could set as like 20 or 30 seconds or whatever. You can tell the device, hey, if this activity goes beyond 20 seconds, then start recording and just download the data or something. Then you can have some idea about the baseline activity by just swiping the magnet. The moment you swipe the magnet, then it will kind of record the data 30 seconds before and 60 seconds after the magnet. And in total, it provides you about 720 seconds of data daily wise. So the great thing is that, you know, it gives you continuous count of electrographic events and epileptiform activity over, you know, days, months, or years. You see here, there was just detection and there was no stimulation or something. After the stimulation was turned on, then there was more and more and more treatment, basically. And then the number of long episodes went down after, you know, stimulations were turned on. So by just looking at this type of activity in terms of the trends, you can understand what happens when you give a medication, or when certain things happen, or when patient needs a medication, or when they have some sort of illnesses going on and everything else. And then by looking at this, you can have an idea about the trends, basically, or the patterns, whether there are certain times where patient is having more seizures, maybe nighttime, daytime, etc. So, in clinic, what we do is we just rely on, mostly, I would say 99% of the time, we rely on verbal reports. So a patient comes into clinic, tells you how many seizures they've had, then you just empirically treat them based on their report. But then a lot of data and a lot of studies has shown that, up to 50% of time, patients' verbal report are not really reliable. So it's kind of like a subjective assessment. But when you have such a device that gives you idea about, chronic ECOG and everything else, then this is great because you have an objective data. You can even have ideas about subclinical seizures on top of like verbal report. You can know where the seizure is coming from, how your medication is affecting the patient brain activity, and you can have idea about epileptic activity trends and everything. And then you can optimize your management based on all those informations. So the first trial came sometime in 2011 about RNS, and it was a multi-center, double-blind, randomized controlled trial, and 191 patients with focal onset seizures with more than 3 seizures per month, despite more than 2 medication trials, were implanted with RNS after 12-week baseline period between 2005 and 2008. Patients were randomized 1-to-1 for stimulation versus sham with blinded physician gathering outcome data for 12-week evaluation period. So in this study, they had a mean seizure frequency remained reduced in stimulation versus sham at 3 months. There was a 29% of treatment group that showed more than 50% seizure reduction in frequency at the end of blinded period, with increase to 46%. Then 7% became seizure-free. And of course, there was some adverse effect, and those were mostly related to initial implantation and everything else, I guess. So after this trial, then RNS approved this device. See, this data shows you, the sham group and the treatment group. So all the patients, got the device implanted, but some were turned on and some were just kept like turned off. The turned off group was the sham group, where they did not do any stimulation, but patient didn't know, of course, like, because when the stimulation happens, you have no idea whether like you are getting treatment or not, because it doesn't, feel it. I mean, you don't feel anything when the treatment happens. So they first few months, they just like kept the detection settings on so that they can optimize and the detection and everything else. And then the moment they turned on, then immediately after a few months, they start to see some seizure reduction. And over time, the outcomes got much kind of better and better. And this is like after like 7-8 years or something, patients, not 7-8 years, I'm sorry, like 9 months or something. So a patient already had significant seizure reduction. So there were there's several kind of studies going on, and one of those was this prospective trial where they included 256 patients with a mean duration of epilepsy of like 19.6 years, and all had like about 10 seizures per month. So most of this, not most, like 1/3 of them had VNS, 1/3 had some sort of previous surgeries done and everything else, and 1/3 did not have any sort of intracranial monitoring. So, and then after a few years, they showed some prelim result from this prospective trial, saying that the outcomes were getting better and better after a few years, and it reached up to almost like 75% at 9 years or something. So, and about I think 10 or 12% or something became seizure free after some time. So similarly, and the seizure outcomes were really good in all sort of lobes, regardless of where you exactly implanted. And although the best outcomes were in the really temporal, parietal, and frontal lobes, they still had some good outcomes in the occipital lobe as well. So they just had limited numbers of patients in this occipital lobe, but even then, 2 patients had like almost like 100% seizure reduction, which is really great. So after this is just comparison of like mesial temporal patient versus neocortical patients. In after almost like 12 months or something, 15% of patients became seizure free in the mesial temporal group, and 14% became seizure free in neocortical patient group after 12 months. Like, it's not just a palliative treatment. Actually, it can be a definitive treatment. Like having 14 or 15% of seizure freedom is just a great thing. That's like 1 every 6 patients. So now all this data was in adult, but then what do we have in pediatric? So as I suggested before, the best evidence level is usually meta-analysis, and this meta-analysis just combines several studies that came out about the pediatrics, and all those studies were mostly, again, retrospective or observational studies and everything else. But then they included about 8 studies in this meta-analysis, and they had like about 49 patients. Median age at implantation was about 15 years, and 63% were male. So most of them had a lesional MRI. Majority had prior invasive studies performed and everything. So they had the implantation in several different locations, including frontal lobe, mesial structures, the thalamus, and everything else. So seizure frequency reduction was all the way up to 75% at the end of like 22 months average follow-up, which is very similar to adult data, which is very promising. And another study that got just recently published in Pediatric Neurology in just like May 2023. So this data is from Pediatric Epilepsy Research Consortium. This is a multi-center study that includes over 22 centers across the United States, and we are one of the site in this study. So they included about, they had followed this patient prospectively, and this data was kind of collected retrospectively. They included about 56 patients that got RNS. The mean implantation age was about 49, and mean duration of epilepsy was 8 years. So most of them tried at least 4 different medications and everything else. They tried previous surgeries, and some failed, diet therapy and everything else. Majority of those patients underwent some invasive monitoring before the RNS. So after about like 11 months follow-up, so the seizure reduction rate was almost like 65%. So 65% had more than 50% seizure reduction, which is a great thing. FDA approves any treatment if you have more than 50 seizure reduction in 50% of the population. So technically this fits the approval criteria for FDA also, but you need some, prospective kind of randomized clinical trials so that it is approved by FDA and everything else. And this is a case series that we just published in Pediatric Neurology. That was the data from Texas Children's Hospital, in tuberous sclerosis. So there were 5 patients with tuberous sclerosis who got implanted with RNS. And as you know, tuberous sclerosis is a condition where you have multiple tubers all around the brain. And it's a pretty challenging condition and pretty challenging disease where you have really difficulty in terms of treatment and everything else. So a lot of time they would require several surgeries and everything else. But even then, with the RNS, there was a significant seizure reduction up to like 86% median seizure reduction after about like 25 months median follow-up, which is pretty promising. Yes, RNS and like other devices, it does provide a lot of seizure reduction and everything else, but not only that, it does provide also neuropsychological benefits. So in those patients who had RNS, there was no decline in any sort of neuropsychological measures. If anything, there was statistically significant improvement in naming, verbal learning, visual memory, and executive functions. So, and then there was, of course, quality of life improvements in several components, including seizure awareness, health discouragement, attention, language, memory, fatigue, and everything else. So you don't get seizure reduction, but you do get a lot of other benefits, when you have those. Again, talking about the SUDEP, so this is even better than VNS. Like in general, the epilepsy surgery candidates would have about like 9 to 10 person, or 9 to 10 every 100 patients would have SUDEP. But then when they used RNS, the SUDEP rate went down to 2%, which is a significant reduction, which is awesome. So yes, it does provide a lot of side benefits, but of course, like any other device, it may have some safety issues. So there was an infection risk of 3.7 per neurostimulation procedure, and some of them unfortunately had to be explanted due to infection, and some of them, which is almost about 2%, had some implantation related small hemorrhages, but that did not have any sort of long-term sequelae or anything. And the great thing about the safety of the RNS is that you can use the MRI, especially 1.5 Tesla. The previous models you could not use because then it would heat up and it would, like damage the tissue and everything else. But the new models with the new models, you are able to use MRI, even though you have some artifact, but still you are able to have really great idea about the rest of the brain beside where it's implanted. So the last but not the least, really, neurostimulation device is the DBS. It's similar to VNS. It's an open loop stimulation. It was first approved in Europe for epilepsy. So before it was approved for epilepsy for many years, I think it was used for movement disorders and everything else. But after this Sante trial in 2018, it got approved for epilepsy also. So mainly approved for patients older than 18 years of age. But again, we have used it off-label as well. So the mechanism is not really, unfortunately, well understood, but it's thought to disrupt the network involved in seizure propagation, as the thalamus is kind of like a relay center and a kind of a center that all the seizure activity kind of cross through to go to the other side or something. So in this Sante trial, which stands for Stimulation of Anterior Nucleus of the Thalamus in Epilepsy trial, it was a double-blinded, randomized controlled trial. It was a multi-center trial. All patients were adult. They had 110 patients. Half of them were female. So mostly had focal and some had multifocal seizure. So blinded phase, median seizure reduction was about 14% in control group and 40% in stimulated group. And in open phase, median seizure reduction was all the way up to like 56%. You see here, after few months of implantation, they already start to see some seizure reduction, which was significant compared to baseline. And again, some people have had some adverse event, including some paresthesia or pain in the site that it was placed. And some patient had infection or lead misplacement. And interestingly, those numbers were higher than the RNS trial. I guess, I don't know, it may be a little bit harder to place the DBS in the thalamus or something, but I'm not quite sure. So then came this trial, Estelle. It's for DBS of thalamic central median nucleus for Lennox-Gastaut patient. It got published in Annals of Neurology in 2022, and this was a kind of a prospective double-blind randomized study. It was conducted between 2017 and 2019. They included 20 patients with LGS, and all those patients underwent bilateral central median DBS. That study was done in Australia. So about 50% of simulation group achieved more than 50% seizure reduction compared with 22% of controls. So again, this is an awesome device, because like we do have so many LGS patient, and those patients usually would have like daily tons of tonic seizures or atonic seizures and everything else. People would try all sorts of different medications, VNS, corpus colostomy, and everything else. They would still continue to have daily seizures. So that device, on top of all these medications and previous VNS and everything else, provided additional benefit, more than 50% in like more than 50% of patients. So again, there isn't, unfortunately, any sort of randomized clinical trial or any prospective trials or anything in children's, but there was this paper published in 2022. It was kind of a systematic review for both DBS and RNS in children. So this study included a total of 35 studies, mostly being retrospective and some prospective for the RNS especially. They had 72 patients who got DBS and 46 patients who got RNS. And this data is from that study, basically, showing that more than about 34 out of 72 patients had more than 50% seizure reduction, a total of like 52. That's almost like more than 70% or something. And in RNS group, there was about 30 out of 42 patients who had more than 50% seizure reduction. So kind of pretty similar result in DBS versus RNS. And this kind of graph shows where the implantation was done. Most of the implantation was done in the central median nuclei, followed by anterior nuclei and some other places. So we keep talking about, focal seizures and everything else, but can it be effective for idiopathic generalized epilepsy? This person, Mark Richardson, I think he's from Harvard or something. So he published this paper in 2022, and they inserted RNS device in the thalamus in the central median nuclei, I think, in 4 patients, and they showed that there were like 75 to 99% seizure reduction after 2 years follow-up or something. And majority of leads end up being in the central median nuclei and some in other nuclei. So each electrode has like 4 contacts, and if you imagine, you can place 2 electrodes in both sides of the thalamus, so total of 8 contacts. But not every contact is going to end up being in the thalamus. So one of them or 2 of them will end up in one of those nuclei, which is why, you don't have numbers ending up to the total of 32 or something. So, and another person published this similarly in refractory genetic generalized epilepsy. They had only 3 patients, but only 2 of them had, some seizure reduction after a period of follow-up. So that suggests that, RNS or DBS can be used in generalized epilepsy as well. And after this trial, this case series, I think they initiated a clinical trial. NeuroPace people started this trial for generalized and genetic epilepsy for patients older than 12 years of age. And the clinical trial is ongoing right now, and we are trying to get involved with that study. We are trying to become a site. So now, we have had all these features and everything else, but, which one we should choose. So it depends on many different factors, of course. So if you have an epilepsy where you have just only 1 or 2 seizure foci, you can literally choose any device you want, VNS, RNS, or DBS. If you are multifocal, again, you can choose VNS. DBS can be possibly used in the thalamus. Even nowadays, people are using RNS in the thalamus for multifocal seizure. In generalized case, people have used VNS for so long, but there hasn't been enough evidence for RNS or DBS. But just like I said, some studies started, they are trying to understand the efficacy of those devices in generalized epilepsy. It's really hard to convince families when you have no enough evidence, but I think eventually we will have some more data, hopefully. So in terms of the seizure onset zone, doesn't really matter much where the seizures are coming from. You can use any really devices. I mean, DBS is usually used for the thalamic implantation, but if you somehow have seizures coming from a couple different spots and you cannot do any sort of ablation or resection, and if the seizures are bilateral and everything else, then you can use the DBS in the thalamus. You can even do RNS as well. So RNS and DBS really can be used in the thalamic cases. It's just the difference is that the RNS is going to have to be implanted in the skull and DBS is not. But with RNS, you can have additional, data recording and everything else. But of course, it's going to be a little bit harder to convince patient to just embed the device onto their skull. In terms of comorbidity, if you have severe depression or suicidality, you can still use VNS or RNS in other, part of the brain beside the thalamus. And they have seen that some of those patients who got the DBS implantation have had some issues with their kind of mood and everything. Some patients have had depression, so better to be careful if patient has some suicidal ideation or suicidal attempts. Maybe better not to use thalamic implantation. So if you have some significant sleep issues, especially obstructive sleep apnea, better not to use VNS, but there's no evidence for RNS or DBS saying that it does affect, sleep problems or something. If you have cardiac issues, then of course, VNS may be a no-no there, but there's probably no issues with the other devices. In terms of clinician preference, if you desire and if you want to have some, intracranial recording, then you should use RNS. If you prefer low programming burden and you're not so technology savvy or something, VNS and DBS are much simpler to use compared to RNS. RNS can be sometimes daunting, to make all the changes and everything else in the settings. And if you want to have some ability for at-home changes, then DBS is the case. With DBS, you can let the patient have some, room for changes and everything. In terms of patient preference, if you don't want to have any sort of issues, any, intracranial complications or whatever, then, VNS would be your choice. If you prefer a chest implantation, VNS or DBS would be the case. And if you prefer cranial implantation, which I don't think if anybody would really prefer this or not, but in that case, your choice would be RNS. So in terms of the device battery lifespan and everything else, the newest model of VNS can go all the way up to 4 to 5 years or so. DBS can be good for 9 to 10 years, and RNS can be really good for 8 years or something. So some patients are worried about like having, several revisions and everything else, but I don't think they need to worry, because like 8 to 10 years is a pretty long, lifetime. So the type of setting that we usually start with the VNS, we start somewhere between 0.125 to 0.25 milliamp in the current. With the DBS is 2 to 3 milliamp. With RNS is 0.5 microcoulomb. And then you keep like increasing those settings up to those targets. Once you maximize the targets, then you can make some changes in the pulse width or frequency. You can change the duty cycle where you change the on and off time. So with the VNS and DBS, you can change on and off time, but with the RNS, it all depends on, the detection settings and the number of stimulation and everything else. There's no like on and off time type of thing for RNS. So just practical consideration, and I think this is my last slide, maybe one before last slide. So if, let's say, you have a patient who you have tried, more than 2 medications and they fail, then you are going to do a pre-surgical evaluation. You'll get tons of studies to kind of have some idea about where the seizures are coming from. If they turn out to be generalized and having some, drop attacks and kind of tonic seizures, you can do either corpus calostomy or VNS, or nowadays we do DBS, for the thalamic implantation for the LGS patient. If not, then you can do hemispherectomies or maybe VNS. If you somehow have some idea about where the seizure is coming from, but not exactly sure the localization-wise, you can do some intracranial monitoring, including a CEG and mapping and everything else. And once you identify the seizure focus, then you will see whether the seizure focus involves the eloquent cortex or not. Eloquent cortex means like, a place where you have those important functions like language and motor or speech or things, memory and things like this. If it's not in the eloquent cortex, the seizure onset zone, then you can do resection or ablation type of thing. But if the seizure onset zone is in the eloquent cortex, then you can do RNS possibly. So if it was hard to localize the seizures and it turns out to be both sides and everything else, if it's just like both sides of the temporal lobe, let's say, or there are like only 2 focus, you can do RNS. But if there are more focus, like multifocal seizures and everything else, or diffuse, you can still do RNS or DBS in the thalamus itself, or you can try other modalities, other stuff. So conclusion, multiple devices are available for invasive brain stimulation for epilepsy with real-world experience. VNS is so far the only FDA-approved neurostimulation device in pediatric age group. Aside from VNS, there are unfortunately not many randomized clinical trials in pediatric DRE, but prelim data suggests that neurostimulation for treatment of drug-resistant pediatric epilepsy is safe and effective. Patient selection criteria have not been well defined, but it's all up to your clinical judgment and everything. There's no guidelines for choosing the best method of neurostimulation in children, and large trials are needed to investigate the efficacy and safety of RNS and DBS in pediatric age population. And I think that's about it. So thanks so much for listening and bearing with my voice and everything. Any questions? Hello?
Can you hear me?
Hello?
Yeah, can you hear us here in neurosurgery?
Yes, we can hear you.
Okay, great. It's a great talk. It's a very nice summary of the various therapies that are available now. I'm curious, in the adult population, what has surprised me is just how much the RNS appeals over DBS. When I read the initial studies, I thought DBS is at least comparable and maybe a little bit better than RNS. But the advantage of being able to see the recorded seizures, I think, has really had an influence on what we like to implant. I'm curious if that's true also in the pediatric population.
Yeah, I 100% agree with that. Like you said, with the RNS, you can have great idea about the seizure frequency and everything else, because majority of our patients, they don't have, unfortunately, good report of the numbers of their seizures and everything else. But with RNS, you can have a pretty objective idea of how many seizures they are having, especially in kids with nocturnal seizures. Most of those people would not even report to you how many seizures they are having. Like I've seen this a lot in the EMU, where a patient comes in and in the morning you ask them how many seizures you had, they will say only 1, but you look at the EEG study, they actually had 40 seizures overnight. Then your management is not optimized in that case. So RNS in that wise will definitely provide much more information. And as a physician, I would prefer RNS over the DBS, but the problem is that, it's so hard to convince people to just like implant a device on their skull, So surgery, when you talk about the surgery, they immediately get like freaked out and everything, then it kind of is easier to convince them for DBS in that case. And also if people are not so technology savvy and everything, then they a little bit prefer DBS over RNS. So that has been my kind of experience.
I've not had that issue. I mean, usually when we're talking about these, I haven't found, and maybe it's the adult versus children because the skull, no challenges with its growing skull, but for adults, I haven't found that RNS, that the craniotomy is a big distraction from it because it's a small, it's a pretty small cranium.
Yeah, I mean, it makes sense when they listen to you, when you talk about getting all the data and everything else from RNS, I think one would definitely prefer. But I guess when you think about your own kid and, having the surgery done on their head and everything else, people prefer a little bit more, DBS or RNS. But as a physician myself, I try to kind of, convince them for RNS or the DBS if possible. If not, then at least I try to convince them for something,
Good.
So let me understand this. The R in RNS is responsive, right?
Yeah.
Right. Okay. So can you not have an afferent limb that is cortical with an efferent limb that is DBS?
Yeah. The distinction is a little bit arbitrary because our DBS devices now, the Medtronic, which is the one that's approved for epilepsy, actually does record. It records the broadband signal, and you can look at different frequency bands. But what it doesn't do, although it has the capability, is it doesn't stimulate that. It doesn't stimulate image.
Yeah. And the problem is that, connecting two devices would be really challenging because they are recording different activity from different spots. And, if you are gonna have some, one device being afferent, the other device being afferent and everything else, you need to be able to connect them so that they talk to each other and they can responsively stimulate, but that's not possibility at this point, at least.
Yeah, I mean, I would see that as an obvious place to develop for the future.
You can use the RNS in this way. You have two electrodes, and you can put one on lateral temporal cortex and one in hippocampus, and you can stimulate the hippocampus whenever you detect activity.
Yes. And actually people have done this with thalamic implantation, where they place one electrode in the thalamus and the other one on the surface. Yes. And so the moment, and they were also trying to understand, the kind of involvement of thalamus, whether like it's the generator of the seizure or if it's just like a relay center, whether the seizure just crosses the thalamus or it's been really generated there or not. So, and they would kind of place, two electrodes, one in the thalamus and one on the surface, and then understand the kind of, the network and everything else. So that can be done with RNS. Yes, I agree. I understand.
I think it's an exciting time. I really think this is changing the way we think about treating epilepsy.
Yeah, I'm especially very excited about this new clinical trial that's going on right now, which is for idiopathic generalized epilepsy, for kids older than 12 years of age. I mean, it would be really awesome. Then that means like you can literally try RNS for any cases, focal, generalized, doesn't matter. Just place the, RNS in their thalamus and kind of be done with it, especially when you have no idea about where the seizures are coming from.
Yeah, no, that's great. We're involved, so that's the Nautilus study. We're involved in that. We actually were implanting our first patient coming up.
Oh, awesome.
And I think Norton is too. I think on the adult side, Norton is also. I think
I mean, I think adult side is already involved. Like, it's just like we have been working with the IRB people to get involved as well. Dr. Machnik is also trying to get involved and everything else. We have one patient who is kind of waiting. We will see, I guess, like once we are in the study, then we will involve one patient or so. It's so challenging though to convince people, because with this trial, they have to turn off their device, like especially if they have VNS or something, and they should have like at least 1 or 2 GTCs per month or so. So they said, like, even if you can find one patient that way, that would be awesome, because they are including more than 35 centers or so. So it's really hard to convince somebody for a device that hasn't been well established over something that has been there more than 20 years or so. We have so many patients, but they would first prefer VNS over RNS. I mean, I try to talk to so many patients, but they are just not going for it.
Yeah, no, I understand.
Yeah.
Okay, great presentation. Thank you very much.
Thanks so much. Any other questions? All right. So thanks so much, everyone. If no more questions, I will have to run to the clinic at this point. And thank you so much, Lilia, for arranging this and everything else. And here is the CMA activity, just in case you missed it. So it's 1282706. Have a great day, everyone.
Thank you so much.
You're welcome. Have a great day.
2076.
706.